Danielle.
So, as Ryan has mentioned, my name is Danielle for Adrian, and I'd like to talk to you guys today about chemotherapy. And the reason I wanted to do this lecture is because I had a close family member that's currently going through chemotherapy, as well as reconstructive surgery after mastectomy. And it occurred to me in doing a lot of the research on this particular subject that not all the information that you would need as a patient is available to you. You have to really search for it, and it's more difficult than it should be to figure out what you need to know, what's going to be happening to your body. A lot of the websites that I've come across put things in very, very layman's terms without really addressing fully the side effects, the long-term effects, and what your chances are of success, or what some of the substitution therapies that they can do for things like modifying loss of fertility, how well that's actually going to work. So that's why I wanted to do this lecture. So, welcome to the discussion of the C word. There are over 50 different drugs that have been classified by the FDA as potential chemotherapy agents. Of those, Canada deals with 20 of them. That being said, I decided to focus on breast cancer for a couple of reasons. A, because I'm not going to have enough time or the attention span to go through 20 different compounds with you. Everyone will be completely asleep by the time I'm finished. So by addressing just breast cancer, one of the main chemotherapy agents that we're using to use for this particular type of cancer, it allows me to give you more detail. And also, this is the #1 cancer that affects women. Another reason it's so dangerous is because the breast tissue is very close to the lymph nodes and lymph tissue. And once the tumor metastasizes into the lymph system, it can go basically anywhere in the body. However, of late, the way that it used to work is that what would happen is you get a double mastectomy. They would remove some of your lymph nodes, and then they look at the lymph nodes and see if any of the cancerous tissue was in the lymph nodes. And if it was in the lymph nodes, you have to go through chemo. Because basically what that was saying is the cancer has been able to get into a root or a system that's allowed to travel. Now, oncologists are less confident making that assumption because we're finding sometimes if you have breast cancer, have your breast removed and your lymph nodes are clean, you can still have it metastasize into different parts of the body. So our understanding of the disease is evolving. I was talking to one of the top oncologists at the University of Notre Dame has a cancer research center. It's called Harvard Hall. And one thing he was saying to me when we did a fundraiser called Relay for Life last year was that in the last 3 years, we found out more about treating and curing cancer than we have in the last 10 years. So this is a field that's expanding very, very quickly because there are a lot of people that are very passionate about this subject. Who in this room knows someone or has had breast cancer? So almost half the room. So that just gives you a rough figure, and maybe some of you are shy. That gives you a rough estimation of how big an issue this is in North America specifically. So this is a picture in purple of the projector of breast cancer. So can you see, this is a mammogram. Can you see the lump, visible lump of the breast tissue? Mm-hmm. So that'd be something you could feel and see. And so this is what we're looking at when somebody says something like breast cancer. Is everyone can see it? It's not mysteriously hiding on anyone? Okay. It's the lump right here. So, which drugs am I going to be talking about today as a bioactive compounds club? There are going to be 6 that I'm going to talk about today. There are more, but I wanted to talk about the 6 compounds that are the most important to your treatment. Fluorouracil, Taxol, tamoxifen, cyclophosphamide is a huge deal, anthracycline, and triptorelin, which is really interesting. There's also trastuzumab, or Herceptin is another name for that, and these 2 as well. If you are interested in looking at these other 3, which are less common or less of the big league chemotherapy drugs that we're using in Ontario, then the references will be a great guide for providing more information on those. Of note, I was speaking with my aunt's oncologist, who's one of the oncologists at the Cancer Center in Hamilton. And it's very interesting because the world has not taken a united front against how they're treating cancer. Chemotherapy has been a very country-specific style or system. In Canada, we're very we're very fond of a certain number of combinations. Versus in countries like France, for example, I found a number of publications that were looking at the effects of a single drug, or a single anthracycline class, or a single cyclophosphamide class. So it's not like you can go to any clinic anywhere in the world and we all are all on the same page. So hopefully I haven't made this too difficult to see. These are the 4 big or top, oh, that's not good at all. 4 top combination of drugs that we use for breast cancer. Unfortunately, it didn't appear as well as I'd like it, so I'll read it out for you. CMF or CAF. This consists of cyclophosphamide, methotrexate, which is an anti-metabolite, we'll talk about what that is later, and fluorouracil. So cyclophosphamide and fluorouracil are 2 of the drugs that we'll be talking about today. Methotrexate works similarly to cyclophosphamide. It's in the same class of drug. The second is EC or CEF, epirubicin, which is an anthracycline type drug, which we'll be discussing, cyclophosphamide again, and fluorouracil again. So you can see that these are 2 very important drugs. The F for fluorouracil or the CEF is optional. Sometimes they use it, sometimes they don't. It depends on the aggressiveness, if you will, of the cancer. If it's something that's metastasizing quickly, it's traveling very aggressively through the body, they're going to give you fluorouracil. If not, it's not worth the risk. As the oncologist that I met with my aunt said, this is the part where we'll make you sick to make you better. And it's a bit of a balancing game because you don't want to make the patient sicker than they need to be. The next is TC, which is an older combination but still effective, and it consists of cyclophosphamide and taxotere, which is a Taxol derivative, which is really interesting. I hope you're going to love it. We'll talk about that soon. And the last is TCH, which is a taxotere, which is a Taxol derivative again, carboplatin, and Herceptin. Herceptin was that, coming back to the list, trastuzumab drug, which was a monoclonal antibody, and we'll be talking about that and a bit of a different application at the end of the lecture. History of chemotherapy. This was really, really interesting. How did we come up with this? How did we discover what now we use on a daily basis curing people of tissue growing out of control? From extreme sadness came something actually that was able to bring hope and cure to the world. You noticed in World War I, people that were exposed to mustard gas had a very low white blood cell count. And at the time, it didn't occur to us that this would have a clinical application. It was just an observation that we had and stacked away and sort of just went, well, I guess that's one extra thing that is a consequence of mustard gas. But then in 1942, we started noticing that mustard gases might be extremely useful in treating leukemia. Leukemia is when the bone marrow starts producing a large number of abnormally formed and dysfunctional white blood cells. And this isn't necessarily, what makes this such a problem is not only do you no longer have properly functioning white blood cells or healthy blood cells for the most part, but they start to overpopulate and push out your healthy blood cells. Treatment with nitrogen mustards were able to circumvent that or kill off or reduce the number of white blood cells. In 1956, cyclophosphamide was discovered, which is an anti-metabolite. We'll be talking about that very, very soon, shortly. But consider this. From that list I gave you, cyclophosphamide was the main ingredient in almost every single regimen that we use. And it's been around since 1956, which is a testament to it really, really works. If it's been around that long, we haven't been able to find something that's better than cyclophosphamide. So this is something that's really important to most chemotherapy regimens. So now we have a drug called mustine, which was used quite often in leukemia chemotherapy agent. And then it wasn't until the 1960s that we started going, if we give people poisonous plants, will it help with cancer? And the answer was yes. There are 2 types of drugs, vinca alkaloids and taxanes, that were the 2 classes of plant compounds that we were found had fantastic clinical applications for chemotherapy. Fluorouracil. So as you noted, this is also a very popular drug in those combinations that I showed you. Because as a cancer patient, you're never going to get 1 or 2. You're always going to get a combination in Canada. And the reason for this is very similar to when you have bacterial infection for which we don't necessarily have a perfect antibiotic. We give you a bunch of different chemotherapy drugs so that if one mechanism, for whatever reason, stops working, like the receptor that chemotherapy agent targets stops being sensitive to the drug, we still have other drugs in that combination that may still be working. So it'll still be killing off cancer cells, and you'll still be hoping to find a cure. So fluorouracil is an antimetabolite. What does that mean? Antimetabolite means that this compound mimics something that the cancer cell is needing for growth. So the registered name of this is Adricil. What this particular compound is a pyrimidine analog. So basically it mimics uracil. It was discovered in 1957 by Charles Heidelberger. And what he did was he noticed that if you take uracil, which is a nitrogenous base found in mRNA, and it's subjected to fluorine, you get fluorouracil. And we found that with the people that were treated with this, what ended up happening was they weren't able to produce thymine. Because what this pyrimidine analog did was it inhibited thymidylate synthase, or it was a thymidylate synthase inhibitor, which means that the methylation of deoxyuridine, so the precursor monophosphate, was not able to be transformed into thymidine monophosphate. So without thymine, you could no longer replicate your DNA. Without replicating your DNA, you weren't able to replicate, and then eventually what would happen is that your cancer cells would die off. The side effects of this included a decreased blood cell count, diarrhea, mouth ulcers, photosensitivity, and dry skin. Your digestive tract, your skin, specifically in your mouth, and your blood cell count is going to be, and hair cells is also are going to be things that you're going to be affected by chemotherapy. Why? Because what this antimetabolite does is it's not entirely specific. It's going to be picked up by healthy cells as well as cancer cells. But the idea is that because these cancer cells are replicating far faster than any healthy cells, it will pick up the majority of these antimetabolite agents and be killed off first. But that also means cells that replicate at a higher rate than would be average in the human body are going to be affected. Things like your hair, things like your digestive tract, which are constantly replicating new cells to line the digestive tract. You'll end up with things like diarrhea or ulcers or digestive issues because your cells aren't able to replicate and renew the troops, if you will, in the endothelial lining, as well as mouth ulcers, photosensitivity in your eyes, and dry skin. Cells that basically would be replicating very quickly. Can anybody else think of another example of cells that would be replicating more than average in the human body and be affected by chemotherapy? Fingernails. Very important in summer. People getting their medication pedicures. People that are undergoing chemotherapy will have very brittle nails, as well as hair loss. So that's fluorouracil. The other thing that is really neat about fluorouracil is that, and this also helps make sure that it's affecting the cancer cells more than it is the healthy cells, is that it's only effective in the S phase of cell replication. So this is a diagram of cellular replication. You have mitosis begins at the end stage, and then in the S, what ends up happening in the S phase is you have DNA synthesis, which is when the cell gets ready, makes two copies of everything, and gets ready to split. Fluorouracil is only active during the S phase. So that means it's going to specifically target cells that are replicating faster. So this is another reason why we're able to administer it to a cancer patient and hope that it will kill off cancer cells before it will kill off healthy cells. Taxol. If anyone has taken the natural compounds course with Dr. Greenberg, they'll recognize this compound. Taxol was isolated in 1971 from the Pacific yew tree, and everyone thought it was going to be the miracle cure for cancer. It wasn't quite the miracle cure, but it's still being used on a very regular basis in chemotherapy agents. It's an antimicrotubule agent. So what this does is that, is everyone here mildly familiar with cellular replication? What ends up happening at the metaphase, the second stage of cellular division, so you have something called microtubules, which form connect to the DNA and pull them to different poles of the cell. And eventually what will happen is a new membrane will form and pinch off, creating two cells with replicated DNA. Taxol prevents the disassembly of the microtubules. So they'll form and hang on to the DNA, but then they won't come up, separate, or deteriorate again. So it's sort of stuck in this position. And that prevents replication. And recall that a lot of these chemotherapy agents are targeted to prevent replication so that the cells will die. Very interestingly, colchicine, which is a drug that's used when you're developing haploid cells in, let's say, a plant genetics lab, works very similarly, and it was originally investigated to see if it too could be a chemotherapy agent, but it ended up being fatal to any model organisms. And the reason why was instead of freezing the microtubules, it disassembled all of them. And what this ended up happening is significantly disrupting the cell structures of not only tumor cells, but also healthy cells, and it was too dangerous or too aggressive to be used as a chemotherapy agent. There's a very small window that we're looking for in a chemotherapy agent. It has to be aggressive enough to get rid of the cancer cells without killing the patient. And that's a very small window. This is a very good example of how Taxol fits in that small window, but colchicine does not. It's too aggressive, or too effective, if you will, and unfortunately, the model organisms that it were used with did not survive. So what this drug does, it's actually, we thought it was from the bark of the Pacific yew tree. It's actually from a fungus that grows on the bark of the yew tree. And essentially what we think it was doing naturally is it was killing off bacteria or other eukaryotes that were providing competition for that niche, that living on the Pacific yew tree bark. So what we've discovered it does is it binds to the beta-2-glutamine subunit of the microtubule, and that's how it does what it does. This drug has actually been also extremely helpful for people that have a valve replacement in their heart. We give them Taxol because it reduces the amount or the rate of restenosis, which means when that valve that you've now, or that you've now put so much work into extending so that blood can flow cleanly through that blood vessel, you give them this drug to make sure that it doesn't collapse again right after you finish the surgery. Because if it does, then you have to open that person up again and put them through that entire routine again. So Taxol is actually used in two main different clinical uses. We have a synthetic derivative called doxytaxol. The reason for this is that isolating this from tree bark is extremely difficult. The only way that we can do it is by a seedling fermentation process. So we haven't been able to grow the fungus in a petri dish or in a lab. It always has to be associated with the tree bark. That's why the synthetic derivative has been very, very useful to us. The side effects, of course, include, again, lower blood cell count, nausea and vomiting, issues with your digestive tract, mouth ulcers, skin rashes, kidney damage, hair loss, and even seizures, as well as liver damage. But the benefits and the increase in survival rate of cancer patients taking Taxol by far outweighs the risks. Tamoxifen. This is something very specific to estrogen-dependent tumors, so breast cancer tumors. The thing about breast cancer is that many of the breast cancer tumors that we're seeing are estrogen-dependent, meaning that estrogen is increasing their growth rate. Estrogen in breast tissue is often responsible for inducing cell replication. So if you have a tumor and then you have a presence of increased amounts of estrogen, this means that you have estrogen telling the tumor to grow even more rapidly than it would without being estrogen dependent. So this creates an entire other category of breast cancer that is troublesome, worrisome, and more difficult to treat. Tamoxifen, which was developed in 1971, was developed specifically to address that issue. It slows the growth of estrogen-dependent tumors. And it does this by blocking the natural hormone. It blocks the effects of estrogen on cell replication in efforts to slow down the replication of the cancer cells. This is another reason why tamoxifen would be used in conjunction with different chemotherapy agents. Because as this slows down the progression or the replication of estrogen-dependent cells, something like cyclophosphamide or fluorouracil can come in and completely finish it off, hopefully. The very unique thing about tamoxifen is that you need to take it for 5 years. Usually a chemotherapy agent is used for several months, but tamoxifen is something that you have to continue for 5 years. And the reason this is done is, first of all, tamoxifen does not create hair, or increase hair loss, but it does. We've seen a strong statistical, a significant value of a number of patients that have not had a reoccurrence of cancer, breast cancer, when they take tamoxifen. This is a safeguard, especially for estrogen-dependent tumors. Unfortunately, it does increase the risk of endometrial cancer or uterine sarcoma. But this risk is by far outweighed by the number or the significant increase in survival rate that we're seeing in cancer patients that take this drug. So yes, it's a very tough decision. It's a very emotionally driven decision for a patient. They're saying to you, well, you've just had your breasts removed, which is something that's extremely difficult to deal with on its own, but then they're saying, we can give you this drug that will decrease the chances of this happening to you again, but it might give you uterine cancer or uterine sarcoma. So it's I can see why tamoxifen will be a very difficult decision for a lot of people to make. But if you look at the numbers, tamoxifen prevents the number of reoccurrences of cancer in a significant number of cases. And then when you compare that to the number of people that are getting uterine or endometrial cancer from tamoxifen, it's significantly lower. But it's still very scary to hear that as a cancer patient. Cyclophosphamide, I'm telling you about this all day. This is a nitrogen mustard alkylating agent. So this is a derivative of the mustard gas discovery observation that I was talking about in the history of chemotherapy. It is oxidized by aldehyde dehydrogenase to make carboxyphosphamide. There are large, and this ALDH, so aldehyde dehydrogenase enzyme, deactivates the cyclophosphamide. So, but a very small amount of that will not be affected by ALDH and will be converted to 4-hydroxycyclophosphamide and aldophosphamide in the liver. Aldophosphamide is the important subunit. What this will do is it will be converted into phosphoramide mustard and acrolein, and these are the toxic compounds. These are the ones responsible for the effect of the chemotherapy agent. So keep in mind, though, that you start out with a certain amount of cyclophosphamide. It's oxidized by ALDH. Only a small part of it becomes aldophosphamide or escapes oxidation by ALDH, and then some of that is turned into phosphoramide and acrolein. So cyclophosphamide is very much the prodrug. So even though there's only a small amount that seems to be getting through, if you will, it's still very effective. And the fact that we have this ALDH oxidation has actually been extremely useful. And the reason for this is that liver cells, intestinal cells, and bone marrow stem cells have innately a large amount of ALDH, versus when a cancer cell does not. So those are the cells that we were discussing previously that are often very dramatically affected by chemotherapy. Your intestinal tract, your bone marrow, the blood cell count was decreased, and a lot of the side effects, as you saw from the drugs that we were discussing. And then there was some liver damage caused by some of the chemotherapy agents. So what makes cyclophosphamide such a great drug is that we can give this to a cancer patient and have a greater amount of specificity for cancer cell death, because cancer cells do not have high amounts of ALDH. So there will be a very small amount of the cyclophosphamide that's going to be oxidized and deactivated, versus in the liver cells and in the bone marrow cells, there's a huge amount of ALDH. So statistically, it's very probable that the cyclophosphamide is going to be oxidized before it can become toxic to the cell, which increases specificity. Fantastic, right? Because we were talking about how chemotherapy is this tug-of-war game between killing off the cancer cells without killing off the human cells, or the healthy cells, rather. So that's what makes cyclophosphamide so fantastic. Unfortunately, cyclophosphamide will induce hair loss, and the other issue is that there's something called chemotherapy-induced ovarian failure, and cyclophosphamide is very strongly associated with this. So women that are premenopausal or haven't had a family yet and are dealing with breast cancer, this becomes a very difficult decision for them, because cyclophosphamide often leaves them infertile. It affects the fertility of both men and women. Anthracycline, on the other hand, doesn't seem to be affecting ovarian function as critically or as profoundly. And in half the cases, when treated with only anthracycline, women that experienced fertility loss, in half the cases they were able to recover menses. That was not the case with cyclophosphamide. And we'll talk about ways that we're trying to mitigate that later. This is called doxorubicin or epirubicin, which were names that you saw on the combinations that I gave you. And it's actually derived from the Streptomyces bacteria, so an antibiotic. And what it does, this is specific for HER2 breast cancer. HER2 is a gene that is overexpressed in a number of breast cancers. So then the way that you test to see whether your cancer is HER2 positive is they basically look to see how much of this protein is present. Breast cancers or tumors that are HER2 positive are considered extremely aggressive. And all it means is that this gene, this HER2 gene, has been overexpressed in the madly replicating DNA of the tumor. The issue with anthracycline is that it's toxic to your heart and is often associated with not heart failure, but damage to your heart. And the way that it works is by intercalating base pairs, which means sticking them together permanently so they can't separate. And if they can't separate, they can't be replicated rather. It also inhibits topoisomerase 2. Because we have so much DNA in one little cell, we have to do what it happens to the DNA is it's supercoiled, coiled extremely tightly so that it can all fit into one cell. The way that we are able to circumvent this and still allow us to replicate our DNA is by having something called topoisomerase 2, which nicks the DNA so it can unwind and be replicated before it winds up again. Anthracycline prevents this, so if it can't be unzipped and it's stuck in that supercoiled position, it can't be replicated. And stopping replication is the main goal in trying to treat cancer cells. It also induces creates iron-mediated free oxygen radicals that damage DNA and cell membranes of the cancer cells. So the reason this is specific to HER2-positive breast cancer is because it binds to a receptor associated with HER2-positive breast tumors. Triptorelin. So this is the drug that we're giving people. This is not considered a chemotherapy drug, but this is our best shot at trying to save ovarian function in women that are scared about losing their fertility. Triptorelin decreases the release of follicle-stimulating hormone and luteinizing hormone, which are two hormones that are released by the pituitary and are extremely important for menstruation. This is considered a gonadotropin-releasing hormone agonist, or GnRH. And what essentially triptorelin is doing is it's given to the patient before they start chemotherapy, specifically if they're using cyclophosphamide. And it induces fake menopause. For some reason, when you're able to make the body think that it's in menopause or deactivate the ovaries for a small amount of time, the amount or the likelihood of the ovaries resuming healthy function after chemotherapy is significantly higher. We're not entirely sure why that works, but apparently it's working quite well. So this triptorelin is a drug that we give people to induce menopause. Turn off, if you will, the ovaries just during chemotherapy so that you can save the function and avoid infertility. This has been extremely successful for women under 40. Some reports state as high as 100% of patients that were under 40 were able to resume menses after chemotherapy when they took triptorelin. Unfortunately, over the age of 40, that percentage drops dramatically. I've seen figures as low as 48 to 40% of patients over 40 will resume menses, even if they take triptorelin. Keep in mind, also, they did look at the number of pregnancies, and there were significant numbers of pregnancies in the women that were tested for this triptorelin trial. But they also found that to resume menses does not necessarily mean that you've been able to successfully mitigate infertility or the deactivation of your ovaries. But it's usually a pretty good indicator. So you can imagine, as either the husband of someone going through breast cancer or the breast cancer patient yourself, if you're hoping to have children but you need chemotherapy, that becomes a big question to you. It becomes something that you have to struggle with. Because even if you take triptorelin, it's not a guaranteed fact that you're going to be able to save your ovaries. You might come out of this completely barren. And that's without breasts and completely barren. That's an extremely difficult emotional decision for someone, and for their family as well. So one thing that's often done is they will remove eggs or freeze embryos so that these people have a chance of having children after chemotherapy. You have to be careful though, because if you have an estrogen or hormone positive cancer, you have to take hormone shots in order to remove the eggs or remove the gametes from the person. If they have a hormone positive tumor, you can't do that, or you're taking a great risk. So triptorelin is the best shot we have at giving someone a chance of being able to have a family after chemotherapy. So these are references. So to end, I did want to bring up a particular Globe and Mail article that I read the other day that I found extremely interesting. And it's a testament to how our healthcare system might be needing to change dramatically. As I said, in 2009, the Cancer Advocacy Coalition of Canada put out a report that stated there are 24 drugs in Canada that have been given the stamp of approval for use in chemotherapy. 24 of them for 18 different new conditions. As of 2007, Ontario only funds 6 of them. So if you need one of those drugs, one of those 24 drugs that isn't in that 6, you have to pay for it yourself. And that can often be in the realm of $22,000 a year. That's a lot of money for someone that has a family and is also trying to recover. Cancer is extremely expensive. In British Columbia, they fund 20 of them. So what we're finding is that the chances of survival or the quality of life after chemotherapy greatly depends on where you live, because there are differences in the access you have, in what drugs you have access to, and what kind of care you will get. One really, really touching example was rituximab. Rituximab is very similar to Herceptin, and that's a monoclonal antibody. And it targets the CD20 receptor protein in white blood cells that have been malformed or are presenting in cases of chronic lymphoma. There was a gentleman in Ontario that really needed this rituximab, and there was a study done in Köln or Cologne, Germany, that restated once again that this drug is extremely effective in prolonging the lifespan of people that are dealing with this type of leukemia. And unfortunately, in most developed countries, it's considered basically the standard treatment for this particular disease. The official title is chronic lymphomatic leukemia, or CLL. So this one gentleman in Ontario was not able to get access to this rituximab drug, which is proven to statistically increases his chance of survival, because it wasn't available in Canada or in Ontario. It was available in BC, in Manitoba, not Alberta, in Saskatchewan, in Newfoundland, in PEI, Nova Scotia, and New Brunswick and Quebec, but not in Ontario. So, and the main issue as to why this is happening, it becomes a funding issue. If Ontario can't afford to supplement and pay for any more than 6 of these drugs, and you need one of those 24 that's not included in those 6, you're out of luck if you don't have insurance. The article that I read was mentioning that many people are actually moving to different provinces to be able to have access to these drugs. So this was a very touching and very interesting article, and you'll have access to this lecture after when we post it on the internet, and it's the first reference point of this Priest L. Article, Unequal Access to Cancer Drugs in Canada, the Globe and Mail. So that's something else that we have to think about as Canadian citizens, is how we can circumvent this, because money doesn't grow on trees, obviously, but we still need people to have access to drugs that they're going to need in order to recover, especially when there is so much statistical data saying that this will increase the chances of them surviving. So it's some food for thought. Cancer is by far one of the most emotionally and psychologically draining illnesses that a person can have in their family. My family and I recently discovered this with my aunt that had breast cancer. And I don't think there's entirely an understanding or appreciation of that. And the other reason why we did this lecture, is that the data as to which drugs are the most popular, how do they work, what are they going to do to you, are not always given in enough detail in most of the websites that I've come across. So The BAC and myself believe in sharing knowledge about drugs and compounds that can affect the human body. So hopefully you'll have taken something from this lecture and have a little bit more knowledge, a little bit more sympathy for people that are going through this condition. Thank you very much.
Thank you very much, Danielle.
You may have touched up on it, I don't know, I came in 2 minutes late. But men's breast cancer in men and women, what's the main difference? I know estrogen maybe is not a factor for men, but is there?
Oh, is breast cancer not a factor for men?
Is it for men?
Yes.
They have more estrogen in their bodies when they have breast cancer? Or?
Yes, we were talking about estrogen-dependent tumors, and that represents a huge class of tumors that we're seeing in breast tissue. So for I think the reason why it's not discussed as much for men is that it's not that men cannot get breast cancer, but it's not as prevalent. In women, it is the #1 type of cancer that women are getting. And in men, I think it's a significantly smaller amount. But if it was an estrogen-dependent tumor, then absolutely. These patients would probably have an increased amount of estrogen, which is feeding or encouraging the proliferation of their tumor cells. Anyone else?
I have a question about Taxol. You said that it's, like other than the other advantages that it had in the ways that it worked, you said it's very effective in terms of increasing survival rate. Like, what, do you have an estimate of that and compared to like other chemotherapy drugs? Like, is there sort of a ranking?
See, here's the thing. I found one article in France that specifically talked about infertility when compared with anthracycline and cyclophosphamide. We don't have that as much of that coming out of Canada because we only give combinations. So we have a lot of data on the combinations of drugs. And I think the reason Taxol is included in so many chemotherapy regimens is because it acts completely differently than most of the other drugs. Most of the other drugs are either anti-metabolites, or they mimic something like a nitrogenous base in DNA, or it has a monoclonal antibody that has a certain receptor that is specific to that type of tumor, or some of those which you made. But Taxol is completely different. It stops the division of, or the disassembly of microtubules. So just because it has something completely different as a mechanism, we often include it, or a derivative thereof, into our chemotherapy regimens, because we're hoping that if the anti-metabolite doesn't work, or the monoclonal antibody doesn't work, or the alkylating agent doesn't work, Taxol still will, just because it's completely off the wall, if you will, compared to the other mechanisms. So we have a lot of data on combinations. Interestingly enough, if you have a double mastectomy and you don't do chemotherapy, you only have a 35% chance of that not coming back, whether or not your lymph nodes. So you've got a 35% chance of surviving, even though you've already had surgery to remove the target tissue or remove the tumors. But if you do chemotherapy, that number often jumps up to 75 or 80% survival rate. So that's why, as I was mentioning, it used to be that if they didn't find cancer in the lymph nodes, they were saying, you're fine, go home, be happy. Unfortunately, that's not the case anymore. We're still encouraging patients to do chemotherapy because it increases your survival rate significantly, from 35 to sometimes 80%. Anyone else have more questions?
I have one more question.
Awesome.
When it's used, Taxol is used for heart valve replacement. Does it have the same duration? Is obviously shorter. Does it induce hair loss or that kind of, or the dosage might be different?
The dosage would be significantly smaller, because the thing about chemotherapy is often several months long. Right. And I got the impression, I have to admit, I was focusing more on how it was used in cancer treatment. For restenosis prevention, it was given, I believe, in much smaller doses for not as prolonged a period of time.
It was very interesting for me to hear that it was used in a moment.
Yeah, because basically what it's doing is you have a collapsed valve or a collapsed artery or something that's no longer working in your cardiac system, and you put in basically a tunnel to help support that and keep it open so that blood can keep going through. But because you've induced some inflammation by putting foreign tissue there, or the body initially will look at that as something it needs to fix or mediate, you'll start getting a large amount of cell replication as it's trying to encompass and heal that area. Unfortunately, this can also induce a reclosing or restenosis of that area. You don't want to have to do surgery on that patient a second time. It was enough the first round. So they would often give Taxol to prevent that or circumvent that.
My younger son would be a future candidate for a heart valve replacement.
Oh, neat.
That's why it caught my attention, and I think
Yeah.
that he will lose his beautiful hair. So.
Yeah, it will grow back. It will grow back. But anyone else have any more questions? All right. I hope you're all experts on breast cancer and chemotherapy now.